all, and good evening all doctors. Myself, Sankalp Sane, a marketing manager from Innovative Life Sciences. Welcome all to this interactive show by Dr. Ritu Santwani, supported by Innovative Life Sciences. Today we have a special guest on our show. She is the teacher of the teachers, Dr. Nandita Palshetkar. Welcome, ma'am. Welcome, ma'am, to this show.
Thank you. Yeah. Thank you.
Also, we have our eminent speaker, Dr. Ritu Santwani. Welcome, ma'am.
Yeah,
And
thank you, Sankalp.
Yeah, we have our CEO, Mr. Amit Mehla, with us on this special show. And over to you, Amit sir, and welcome to you.
Yeah, hello, Amit ji.
Hello, madam. Hello,
Yeah.
madam. Welcome, madam. So very good evening to all of you. Warm welcome on behalf of entire team of InnoCare in this webinar series of Pundit show.
Thank
And
you.
today I have privilege of welcoming teacher of teachers, Dr. Nandita Palshetkar, in webinar series of Pundit show on the topic, how to preserve the biological clock. And now for the new viewers, because many of viewers would be attending for the first time. As far as Pundit show is concerned, is a platform for experts as well as young doctors. And Pundit show is the only show which has been running for last 4 months continuously on all weekends. The unique thing for Pundit show is not only doctors from India, but from across the globe. All over the world, doctors are getting benefited from this show. And Pundit show has been covering all aspects, be it gynecology, obstetrics, sexual wellness, women's health, medico-legal aspects, and current pandemic COVID, and so many other topics. Now I'd like to request Dr. Ritu kindly introduce Dr. Nandita Palshetkar.
Yes. Yeah.
Welcome, Dr. Nandita. Welcome again.
Yeah. Thank you so much. A very, very warm welcome to our very own dear Nandita ma'am. Ma'am, आपका दिल से स्वागत है.
I love you.
Thank you, ma'am. Thank you. Ma'am, these lovely flowers are our very own Nandita ma'am. मतलब हम हक से कह सकते हैं कि हमारी अपनी Nandita ma'am.
Thank you. That's so beautiful.
Like you, ma'am. So friends, before I introduce the ma'am, so as all of you, the Nandita itself meaning the delightful, the happiness. So ma'am is like that. Ma'am जहाँ पर भी जाती है वहाँ खुशियाँ बिखेर देती हैं. So first I will read some lines for ma'am. Then we will start the show. As friends, as all of you know, the Nandita madam is MD, FICOG, FCPS, FRCOG. Ma'am is director at 9 Bloom IVF Centers. Ma'am is professor in OBGY, DY Patil Medical College, Navi Mumbai. Teacher for super specialty degree, FNB Reproductive Medicine. Practicing infertility for the last 25 years. President MOX 2020 to 22. Former President Foxy 2019-20. Former President MOX 2018. There is lot of achievements in the Madam CV. Former President for IH. Vice President of ISAR in 2020. Former Chairman for MSR. Ma'am have written more than 150 chapters. Ma'am received so many awards and delivered the 51 orations and delivered more than 1,000 talks. So ma'am has so many of achievements. अगर वो मैं achievements पढ़ूंगी तो हमारा आधे घंटे का शो इसी में खत्म हो जाएगा. Ma'am, a very, very warm welcome to you.
Thank you.
Before I will start asking some questions to ma'am, I want to say 2 lines for you, ma'am. Ma'am, ये लाइनें हमारे दिल से हैं, जो हम सारे लोग we all are inspired by you. ना जाने कौन सी दौलत है कुछ लोगों के शब्दों में, ना जाने कौन सी दौलत है कुछ लोगों के शब्दों में, वो बात करते हैं तो मन ही खरीद लेते हैं. So ma'am, very, very warm welcome to you.
Thank you.
Ma'am,
so
first,
beautiful.
ma'am, this is our own feelings. So ma'am, I want to know, ma'am, as you are a role model, हम जितने भी गायनिक हैं हम सब आपकी तरफ देखते हैं. हम सबकी ऐसी इच्छा होती है कि हाँ हमें आगे कुछ बनना है तो नंदिता मैम की तरह करना है. So ma'am, please share us some few tips for your success mantra.
I think if you look at my life, it's been ups and downs, of course, but I think the main driving force was passion. I think I was lucky that I found something that I was very passionate about. So you need to have a kind of a focus and my sense of belief in myself, that I know that I'm capable of doing better. So passion with that sense of belief, I think, is a combination for success, Ritu. And another thing that is very, very important as you grow in your field or even at the beginning of your career, I think it's empathy. Meaning the feeling for others, because whenever I have always, let me tell you of an incident that happened in my life. I was a medical student and my mother had some white discharge and everything. So I got her to the JJ hospital OPD. I was a student that time. And the doctor there saw her in the OPD and said she has got cancer. But just like that, she's got cancer. Okay. Our whole house was devastated. We were totally shattered, with that one word of that doctor. Then we took her in private. We did a pap smear. We did everything. And fortunately, it was not cancer. But that's where I learned that, you have to put yourself in the patient's shoes. Because it can be, very difficult for the patient. So I think that empathy, which we doctors need, and especially when you're in this field, is very, very important. So passion, sense of self-belief, empathy, then communication also. I think it's a very important mantra in your life that you are able to communicate with others. And another thing which I think in my life is appreciation. I appreciate small things of life. Yes. Today, you calling me on Teachers' Day for this and calling me teacher of teachers. I mean, that has touched me. Yeah, so I am very, very, very happy about it. So that appreciation which you've given me, I think it goes a long way, Ritu. And appreciation is very important in everyone's life. And I think if you give appreciation to your peers, to youngsters and older people alike, I think that makes you a very good human being.
Thank you so much, ma'am. Friends, I want to share with you all, in spite of having such a busy and tight schedule, when madam told कि ma'am कि हाँ एक बार हम dry run करके देखेंगे show का, whether the presentation is going or not. Yesterday night we had done at 11:45 the dry run of the show कि जिससे कुछ practically कुछ problem नहीं आनी चाहिए. So ma'am, hats off to you. And ma'am, and one very good quality of the ma'am कि कितने भी मैम बिजी रहे, कितनी भी कॉन्फ्रेंस में कितने भी लोग हो, हम लोग सारे लोग जितने भी फॉक्सी कॉन्फ्रेंस अटेंड करते हैं, सबकी एक तमन्ना होती है एक मैम के साथ सेल्फी जरूर होनी चाहिए. तो मैम कितने भी बिजी रहे, मैम कभी भी मना नहीं करते. अगर हम दूर से खड़े होकर देख भी रहे, मुझे अच्छे से याद है एक कॉन्फ्रेंस थी बॉम्बे में, मैं बहुत देर से देख रही थी कि मैम फ्री हो तो मैं जाती हूँ, मैम को बोलूंगी एक आपके साथ फोटो खिंचानी है. मीन्स आई वॉज थ्रिल्ड. मैम ने मुझे खुद बुलाया, रितु तुम वहां क्यों खड़ी, आओ तुम यहाँ पे आओ, जितने लोग ज्यादा होंगे मोर द मैरियर, मैम ने बोला था, मुझे अभी तक अच्छे से याद है. सो मैम, हेड्स ऑफ टू यू. मैम, वन मोर थिंग आई वांट टू नो, मैम आपके इन योर फैमिली हाउ यू डिसाइडेड टू गो फॉर इन दिस प्रोफेशन, फॉर दिस डॉक्टर?
It's really crazy because हमारे फैमिली में कोई मेडिसिन नहीं करता, कोई डॉक्टर नहीं है, कोई नहीं है. बट जब मैं बच्ची थी तब से मुझे डॉक्टर बनना था.
Okay.
I don't know. It is just that डॉक्टर बनना है. बट या IVF मैंने ऐसे चूज किया क्योंकि मैं जब जेजे हॉस्पिटल के ओपीडी में बैठती थी, ओपीडी में एज अ रेसिडेंट, तो वहाँ ओपीडी में आधे पेशेंट्स ऐसे आते थे, मैडम ये हमको अनवांटेड चाइल्ड है, हमको MTP करवाना है. और आधे पेशेंट्स ऐसे आते थे कि मैडम हमको बच्चा चाहिए, हमको इनफर्टिलिटी है, हमको बच्चा नहीं हो रहा है. तो मुझे ऐसा लगता था यहाँ से बच्चा उठा के यहाँ डाल दूं, कि उनको हेल्प करूं. सो आई थिंक माय पैशन, माय इंटरेस्ट वाज किंडल्ड ओवर देयर. I would like to go into infertility to help these couples have. And, Ritu, when I was studying, there were 3 things that were really happening in our, in the country that time. I was working in a unit where their technique was very good. We had Dr. Purandre, Dr. K.K. Deshmukh. They were fantastic surgeons. So, surgery, Dr. Lopez, surgery. Yeah. So, the technique was fantastic, superb surgeons. Then, I used to always wonder whether to take the technique or the technology. I was at the crossroads. टेक्नोलॉजी जाओ या ये अरे बाप रे क्या टेक्निक है क्या सर्जरी है चलो वो करते हैं but of course I finally went into technology and I decided to go in that direction but I think that was one of the things that was happening in those days. Endoscopy was there, genetics had come in and all those new things in the horizon and it really made a lot of difference.
Okay. Thank you so much, ma'am. Ma'am, there are some doctors are requesting for us to start the lecture. So first we will listen with ma'ams how to regarding this biological clock. Ma'am, some doctors have joined from the Nigeria. They have dropping the message.
So today we are going to discuss how to preserve the biological clock. I think that's an eternal question which has been there all down the ages. And women definitely, for them, the biological clock is ticking and we always are looking, the Amrit which was there in our mythological days, which would preserve the woman, preserve the man. But definitely we haven't found our Amrit yet. But let's look at something which is close to it. I think if we look at science, the cryopreservation was something remarkable. There are many disruptions in science which actually bring about a great change. One minute. Sorry. So cryopreservation was one of those milestones which brought about a major change. And that was something that was really needed and it gave IVF a new life. And I will tell you why. If you look at this picture, this is Miss Diana Hayden and her husband Colin. They are right now in Nairobi. There are a lot of people from Africa. They are in Nairobi. And these are the 3 children born. And Diana has had these children at the age of 40 plus. You know how this was possible? Diana was a young girl, Miss World, in 2006. She came to me in December. I think it was 2006, December. Yeah, she came to me and she said, I have heard of this technology in America about egg freezing and I want to preserve my eggs because I haven't found the man of my choice. And I'm busy with my career and I want to do a lot of things. She was the ambassador at that point of women's health. She was into, breast cancer, etc., etc. So when she came to me and we froze her eggs at the age of 34, and today look at that, we were able to stop her biological clock and give her these 3 beautiful children when she was ready for them. Another example that I want to tell you is about Ekta Kapoor. I'm talking about these girls because they are icons and we have mobilized and motivated a lot of women. When these girls came forward, Ekta Kapoor had frozen her eggs for 7 years before she had the baby. And she also is a dynamic, empowered girl who hadn't found a partner. Then finally she decided to have a child as a single mother. So these are the cases where social freezing goes a long way. So biological clock can be preserved for a lot of indications. Yes. Social reason is one of them, Ritu. Poor ovarian reserve. Nowadays, I see a lot of young girls, with poor ovarian reserve, 30-year-old with AMH of 0.7, 0.8. That's probably because of pollution, because of autoimmunity, because of stress. And it's very important to check the ovarian reserve of these girls. Then iatrogenic poor ovarian reserve. You have endometriosis, you've done cystectomy, or you have benign cysts, you have recurrent dermoid cysts for which you've operated, or even, BRCA1, BRCA2 cases of breast cancer where you do a salpingo-oophorectomy. You can have poor ovarian reserve with that. Genetic causes like Fragile X syndrome, then Turner syndrome, all these people have a low ovarian reserve. Autoimmune disorders, SLE, we give drugs which are toxic to the ovary. They can cause a low ovarian reserve. Of course, cancers, because of chemotherapy, radiotherapy, we can have poor ovarian reserve, and patients of bone marrow transplantation. So these are the immense number of people who actually need the biological clock to be preserved. And how can we help them? And that is what we are going to discuss today. So I just want to iterate that BRCA1, BRCA2. In fact, BRCA2 patients are more at risk of PF than BRCA1. Turner syndrome, deletion of X chromosome, fragile X syndrome, all these patients have. Then, fertility preservations like delayed childbearing, social reasons like career, late marriages, finding the right partner, history of early menopause in the family. Ovum donation program is another program which is there for cryopreservation. Then in ART, we use cryopreservation in OHSS. Semen samples not available, low responder patients where we do egg pooling. And then the endometrial thickness may not be appropriate. And of course, in certain in countries like Germany and all, you cannot freeze embryos. So you might just freeze the eggs. There was the study about age-related decline, knowledge about how many people know. And it was really dismal that people did not know about egg freezing. And that is why I think I must congratulate Ritu that you have taken this very innovative topic, because the awareness is not there. And I think we really need to talk about it and the awareness of this technology which is available to everyone now. So Ritu, I'm really happy you took on this topic as for the seminar. So when we talk about fertility preservation, I think the counseling is very important. You talk to them about what's fertility preservation. Of course, the options are egg donation is available, adoption is available, etc. Now, in cases of cancer patients, I will discuss this a little later in the next slide. So what is the first step in cryopreservation? First is ovarian stimulation. So ovarian stimulation is very simple. You can start on day 2, and usually in patients where you're, doing ovarian and oocyte cryopreservation, you like to give an antagonist cycle. So day 2, you start an HMG or an FSH, you continue it and give the trigger of a GnRH analog. Okay, and then do the pickup and freeze the eggs. So antagonist cycle with the analog trigger, so that you don't have to worry about OHSS. Now, cancer has really taught us that you can stimulate the cycle anytime. In fact, the August issue of 2020 Fertility Sterility, there are beautiful articles on physiology and the beautiful physiology of how random start makes sense. What is how you do ovulation, what is the actual rise, what causes the ovulation, etc. is amazing. It is beautifully mentioned in that. And Ritu, maybe next time I can give a lecture on that. The different physiology and what we know today is not the same as we had learned 30 years ago.
Great, ma'am. Great.
The random protocols where we can start anytime. You can just start your FSH, HMG injections and use the antagonist protocol, give the trigger and do the pickup. And you get good number of eggs. So what is the procedure? Procedure, as I said, you've done the ovarian stimulation, which is hardly 10 to 14 days. This is the counseling that you tell the patient. So you take injections for 10 days, you do 4 sonographies, and then you take the trigger and you get admitted into hospital. Once you get admitted, we do the egg retrieval under anesthesia. It takes about 10 to 20 minutes to get all the eggs out with the help of the ovum pickup needle. Once the eggs are retrieved and are in the laboratory, we let the eggs incubate for 2 hours. Okay. After 2 hours, we start the denudation. And after denudation, the cryopreservation process starts. So you've identified the eggs as M2s, M1, and GVs. So the M2s and the M1s are the ones which you freeze. So cryoprotected after 15 minutes. And then, of course, depending on whether we are doing slow freezing or vitrification, the process is done that way. There's storage of, and once they are either frozen with slow freezing or vitrification, they are stored. And when you want to use them, we do thawing, then we do ICSI after 2 to 3 hours with spindle view and laser hatching prior to embryo transfer. So this is the whole process of getting the eggs and achieving a baby. Of course, the storage can be kept typically from 5 years to 10 years. In England, it's allowed only for 5 years. But during COVID times now, they've increased it to 10 years. As I told you, my patients whom I mentioned have kept them typically from 7 to 10 years. So what is the difference in the technology? There's slow freezing and there's vitrification. If you can look at this graph, this blue line which is there, the blue line which is there is a drop in temperature from plus 37 degrees to minus 96 degrees. The drop is minus 25,000 degrees centigrade per minute. It's so rapid, and that is vitrification. So there are no ice crystals which will damage your spindle. Whereas in the slow freezing protocol, there is a certain gradient of dropping of the temperature, and it has to be in a freezer which is computer controlled, and it controls the drop of temperature, and that it can form ice crystals, especially in the extracellular space, and that can damage your oocytes. And I must tell you of one example of my patient. In November, I had this celebrity patient who came to me. She had 9 embryos, and we did not have this technology. That time it was slow freezing. So I had frozen her 9 embryos with slow freezing because obviously she was beautiful, lean, thin, PCOS, and she had gone into hyperstimulation. So we froze all the embryos. And then after her OHSS had subsided and we thawed the embryos, I was able to give her only one baby, out of those 9 embryos.
Okay.
But Diana, who was frozen in December, and in November we had got the vitrification technology. And Diana, who was frozen in December, has had 3 babies from her eggs. So that was the efficiency of the slow freezing, the vitrification compared to the slow freezing. In slow freezing, you got 30-40% of the embryos back. But in vitrification, you get 99% of the embryos back. So that was what really revolutionized the whole IVF. The success rate, which was 30%, jumped up to cumulative pregnancy rates, which are now in the range of 60% to 90% over 4 to 6 cycles. So this is the technology which has brought about a disruption in our field, and it's amazing. And this was the famous Anna Cobo's, RCT, where she showed that 16 studies, 3,000 plus patients, where the odds ratio showed completely in favor of vitrification, that it was a fantastic technique and gave wonderful results. Our egg freezing data at Bloom IVF today, as far, we have 17,000 plus eggs frozen. The donor oocytes, actually, there's a slight mistake. The donor oocytes are 12,000, about 10,000 plus. Okay. And social egg freezing, we've done 7,000. So total number is about 17,000 eggs, and the success rates, as you can see, is 56% in a fresh donor cycle, and thaw donor cycle is 64%. And believe me, it is a fantastic technology. And thanks to these 2 patients of mine, who have talked about it openly, and a lot of girls from the Bollywood, from pharma industry, lawyers, a lot of mothers came with their daughters who were going abroad for education to freeze their oocytes, and a lot of other patients, which I'm going to discuss further, have come and frozen their eggs, and it's a fantastic technology. So age and number of eggs is really important. If you look at it, that if you want one good euploid, normal chromosomal embryo, Then if the patient is younger than 35, less than 5 eggs are enough. Between 35 and 37, 5 eggs are good enough. 38 to 40, you need 7 eggs. 41 to 42, you need 10 eggs. And more than 42, you need 20 eggs. Now, this is something that you need to remember when you're doing cryopreservation of patients. And you need to do the counseling and to tell them. Sometimes, in cancer patients, I need to do multiple cycles because their egg reserve is lower. And if we get a chance, we definitely do it.
Very nice.
Yeah, endometriosis is something else, Ritu, which is something which is very close to my heart. And I want to tell people that when you're treating adolescent patients, when you're treating young girls who don't want to get married, who are not yet married, remember when you operate for endometriosis, you're reducing their ovarian reserve. And secondly, it's a recurrent disease. Please give them post-operative medical therapy. And keep checking on them, keep doing follow-up on them, do ultrasounds, follow-up AMH for the ovarian reserve. And if you feel the AMH is dropping, do their fertility preservation. Don't tell them, that you've got endometriosis, now you better get married fast and have a child fast. They don't want to do that. So offer them fertility preservation. And in fact, I don't have that study, but Anna Kobo in Fertile Sterile July issue of 2020, she had something like 600 plus patients, and they were all endometriosis patients, and they did fertility preservation before undergoing surgery, and it's been fantastic for them. Not all of them needed it. See, remember, it's an insurance policy. We spend 1 lakh on our cars, no EMI. Don't we do that? So why do you not spend it on your fertility insurance? We all take life insurance. We should do this to preserve our fertility. Because trust me, Ritu, every girl wants to have her own child. She doesn't look for egg donation. So I think in endometriosis, we really need to look at it. Then benign non-endometriotic cysts also. Any kind of ovarian surgery reduces the AMH. So we really need to be, more vigilant, be more careful. When we are talking to the patients, we should be telling them. Let me tell you of this patient I had who had a recurrent dermoid cyst. She had 2 dermoids, 2 surgeries done, and she had come to me with a 3rd dermoid. So she said, Doc, I said, you have to remove the dermoid. So what we did was, we did stimulation. We removed all her oocytes without puncturing the dermoid. You have to be very, very careful when you do ovum pickup. You have to avoid that dermoid. And we removed all the eggs, preserved them. Then she underwent a cystectomy. And she hadn't yet found a partner. So we were able to preserve her oocytes, because sometimes the oocyte accumulation strategy is much better, because it gives her a better chance of future pregnancy. So dermoid endometrioma, pseudomucinous cyst, all these are good chances. Our country has tuberculosis.
Yes.
And tuberculosis really, the ovarian reserve drops, and there are enough studies showing that. Very own Malhotra's study in 2012 and Sharma's study actually says if you treat genital tuberculosis, the ovarian function improves. But these are again patients where there is poor ovarian reserve, and oocyte accumulation would be very good for these patients. And if they are married, to preserve their biological clock, I actually freeze the embryos and I keep them. I keep pooling the embryos. So I may do 3-4 pickups. Take the embryos, freeze them and keep them, and then maybe, treat them. Also, age is very, very important. Remember, Ritu. So if the patient is older, you can actually preserve a fertility and keep the oocytes, as we did for Diana and Ekta. The age is also an important factor. So fertility preservation as such should be done under the age of 35. But let me tell you of an example of this girl who had come to me. She was 27 years old and her AMH was 0.8. Now, when I first saw the AMH, I couldn't believe it. Now, remember, friends, one thing is very, very important. When you get a report of AMH 0.8, you must repeat a second report. You can't just label a poor ovarian reserve on one report. You need to repeat the report. So my advice is repeat the second report at least at a 2 to 4 weeks interval and see. And if she's poor reserve, then we give her all the adjuvants. I use DHEA, I use melatonin, I use CoQ, arginine, even testosterone gel, growth hormone during stimulation, etc. to collect all the oocytes. So it's very important. And this 27-year-old, I had to freeze the eggs. But remember, at 27, if you freeze about 5-6 oocytes, it's good enough to give one baby. So we got 10 eggs in her. And remember, when the age is young, the antral follicle count is good. You may land up getting better eggs. So please do it for these patients. I have done it for a lot of 40 plus women also. 40 plus women, what we do is we get all the eggs out, create the embryos, and then, Ritu, I'm doing this non-invasive genetic testing.
Okay.
So NICS actually, it's called non-invasive chromosomal screening. And if I get a normal euploid embryo in a 43-year-old, you know what is the pregnancy rate, Ritu? As good as a 27-year-old.
Great, ma'am. Great.
So it's a fantastic technology. Use the technology today, which is available to you to give good results to your patients. I think it's an amazing field to be in. Now, I'll just take you through 2-3 slides only of cancer patients. I'm not going into detail too much, but you have to, this is a chart which I keep in my clinic because I do a lot of fertility preservation for cancer patients. And as I told you, the 7,000 eggs that we have, a lot of them are cancer patients also who have gone for cancer therapy. So these are the drugs. There are drugs with high risk. Those are the ones which should go for fertility preservation. Intermediate risk, I do advise them. But low risk ones are the ones I tell them there's no need because you will conceive naturally on your own. And it's very possible that you will not have any fertility problem. And very low or no risk. So these are the drugs. I can't remember them at all. If after the lecture you ask me, I have to go back to my slide. These are questions, okay? I keep this in my clinic, and that's how all my residents also, know about it. Okay. Yes. Then risk of ovarian metastasis. This is also kept in the clinic. It's kind of a chart that is there. The best patients where ovarian metastasis is important when? Because we do a lot of ovarian tissue freezing also. So some cancers, it's better to do ovarian tissue freezing, like breast cancer stage 1, 2, and infiltrating ductal type. So you can remove the ovary because they are sensitive to tumor. They are sensitive to the estrogen, progesterone. So their BSO is advised in these patients. So breast cancer, squamous cell carcinoma of the cervix, Hodgkin's lymphoma, osteogenic carcinoma, Wilms tumor, non-genital rhabdosarcoma. The high risk is a leukemia. It's a no-no. Ovarian tissue freezing is a no-no. But I'm going to tell you something new that has been done in Burkitt's lymphoma and leukemia. And pregnancies have been achieved. And I'm going to give that as the last thought process to everybody before going home. That yes, today technology has really changed and we can do a lot of things. But this is again something that I keep in my clinic because we are not onco-fertility. We are not oncologists. So as onco-fertility specialists, we need to keep this in our clinics if you're going to practice onco-fertility. So this is very simplified way in which we treat patients. Supposing a patient comes to me and says, I don't have any time. I have to start immediately my treatment to the next day. Then we do the laparoscopy and ovarian tissue removal and just freeze the ovary. Okay? Supposing the patient says, I have 15 days. then we do ovarian stimulation. Or we give GnRH depot. So these are the things that we can give if depending on the time to gonadotoxic therapy. Okay. So this is the combination. You can use laparoscopy, you can use stimulation, you can use depot. So nowadays we're doing a mixture also. We do ovarian stimulation, preserve the eggs, remove the ovary after that, and preserve the ovary also. Okay. So you can all these combinations. It is all individualization. It is very specific to the patient. Then also radiotherapy. Not every dose has a bad effect. You can see this, the dose which reduces the ovarian pool follicles to less than 1,000. 1,000 means menopause. So this is again something which you keep in your clinic and you know about it, and you maintain it. See, generally the cancers which affect the young girls are the hereditary cancers. Like BRCA1, BRCA2, Lynch cancers, etc. So remember B Lynch cancers, etc. So these are the cancers which affect younger girls, and for them they can be prevented also by cancer sparing surgery, it's known as. So which is bilateral salpingo-oophorectomy. Now in these cases the ovary is preserved, and you can actually preserve their fertility and give them a better chance. So and also whenever they want to have a child, remember that these are usually autosomal dominant genes. So you can give it to your child. So there is a 50% chance that your offspring may have the same gene. So you can actually do NICS, that is PGT-M, PGT for monogenic diseases, that is autosomal dominant gene is identified in the baby, and those embryos are taken away. They are not put back into the womb. So you can have the next generation which is completely free of this disease. So remember, this is the counseling that you need to give your patients who have these problems. Yes. I really love this. You have to tell me about the time, otherwise I can go on and on.
Amazing, mesmerizing lecture, ma'am. So many doctors are joining. I'm welcoming some from the Germany, some from the Nigeria. So
okay, great.
Very nice. Yeah.
And there's autoimmune disorders also. See, now autoimmune disorders you see in young girls, and cyclophosphamide therapy is given. You can give GnRH agonist to these girls. Ovarian stimulation and cryopreservation of oocytes is also possible, and if sufficient time is available. But remember one thing, these girls require effective thrombosis prophylaxis. So LMWH is really, really important. And if ovarian reserve is sufficient, cryopreservation of ovarian tissue is also an option before you start these toxic drugs. But oocyte cryopreservation is much easier. And this is very radical. It's still experimental, the ovarian cryopreservation. So you need to take permission, etc. Factors affecting the success rate. I think the age is the most important factor. Earlier the age, that is the quality of your eggs. So obviously the age is important. The cause of infertility, because endometriosis reduces the ovarian reserve, etc. Cancer reduces the ovarian reserve. Then whether it's donor or non-donor, then you have good quality eggs, you have good number of eggs, so there's no problem. Stimulation protocols, like supposing she's sensitive, the breast cancer is ER/PR positive, HER2 was strongly positive, then obviously you have to use letrozole protocol, so there are less number of eggs. Then the number of oocytes that you get, the cryopreservation method is generally vitrification, and of course indication. Is ovarian tissue freezing superior to egg freezing? Yeah, because it's more natural, no? It restores the natural fertility. But the drawback is, of course, in those cancers, where you have a higher chance of metastasis, it should not be used. Live birth rates are around 30% after cryopreservation, and I think all over the world, Donez, Klaus Anderson. I had gone to Denmark to learn ovarian tissue cryopreservation, and we've done about 4 so far in our clinic. But it's a fantastic technique which helps a lot of girls. Okay. Yeah. Then this is the latest systemic review about live birth rate after ovarian tissue cryopreservation, which was in 2019. It was published, 20 studies, 40 patients, and it's 20, the live birth rates were somewhere from 4% to 14%. But remember, these are all, different, because a lot of patients are told to conceive naturally. So that has not been included in it as yet. So there is a bias in this systemic review because of the studies which were included. Then, of course, remember that leukemia is the worst. So refrain from transplanting the ovarian tissue in cases of leukemia, because there are micro metastases which you cannot see. And autotransplantation is safe in lymphoma patients. And laparoscopic oophorectomy, in children you cannot preserve their eggs. So in children, it has been done. This was 2019, and ovarian tissue cryopreservation remains an experimental means of fertility preservation in children, but it has shown to give good results, and there was a meta-analysis which showed that it has really good results. And this is there are new techniques which are there, xenotransplantation. So you can transplant the ovarian tissue into immunodeficient animals to generate oocytes, especially when there's a high risk of tumor cell contamination in the ovarian tissue, and oocytes can be obtained, to create the embryos. So far, no generation of embryos. Then in vitro growth is cultivation of the ovary tissue or isolated follicles to generate oocytes. And artificial ovary, let me talk about that. So Octay is a guy who's done fantastic work in breast cancer. And in American Journal of OBGYN in Jan 2016, he published these 2 case studies where, he used alloderm. Alloderm is what? It's used in cosmetic surgery. It's an extracellular tissue matrix. Okay, and you put on it any type of a stem cell or any type of a cell, it creates that tissue. So say you want to create a muscle, you want to create, a bone. You just put this alloderm and you seed it with that particular tissue. So what Octay did was that in these patients, I think one was a Hodgkin's lymphoma and one was a leukemia patient. He took follicles from the ovary. He decellularized that ovary completely. So there were only primordial follicles. So there's absolutely no cancer cell, only follicle. He took those follicles and he put it on this ECTM, alloderm. It is cultured outside the body for 2 weeks. And after 2 weeks, the ovary is nicely formed. And then this is taken in with a laparoscopy and put back into the ovarian fossa. And he achieved pregnancies in these 2 patients. So it's fantastic. Susan Ford's conference I attended in 2019 in New York. She has created an artificial ovary, using a 3D imprinting of the ovary. And you can do that. So sky is the limit to what you can do, and you can really use technology to do this. Okay, so I would like to say that, friends, remember, life exists after cancer. When there's cancer, people just give up on everything. But I think cancer treatments today are good. People do survive and they want to become pregnant. I have so many patients who come back and say they are lymphoma survivors, etc. They want to have a child. So life exists after cancer. Talk to them about their fertility preservation. Fertility insurance for girls is like a life insurance. Fertility focused to pelvic surgery needs to be integral to training, because you cannot do pelvic surgery like a butcher and ruin those ovaries. You need to treat that ovary with love, with passion, with care, so that you don't damage her future fertility. And one take-home message which I want you to take back. Look at these 2 scenarios. This happens in our day-to-day life. I had this one girl who was married and who was working. She had a child and she took leave. She got married, at 34, 35. Everybody gets married at that age. She had a child, she took leave. 1 or 2 years, 3 years go and all that. She comes back to her job. She's at the same position at work. Then they both decide that she wants to have a second child. She again takes a leave. So she's at the same position in her career for after 6 to 7 years after having 2 children. She's busy with child rearing because obviously they can't afford to have a, nanny and everything. It becomes difficult to do everything. Reaches 40 with very little advancement in career. Take a look at the other girl on the other side. She's married and working. She comes to me and freezes her eggs. She advances in her job, advances in her career, and becomes the CEO of a company at the age of 40. Has a child at 40, employs health, and achieves whatever she wants to do. People today, women need to have the right to be able to choose what they want to do. And this biological clock should not stop them from doing what they need to do. And this is women empowerment. And we as doctors should be able to give them this choice. I'm not saying do it in every woman, but if the girl wants it, who are we to deny it to her? It is an ethical conundrum. But now, with all the girls being healthy, I think we are all treating, pregnant, elderly pregnancies. And with the advances in technology, we can definitely take care of them. And I think it is that girl's right. It is important to empower her and give her that option. Thank you. Thank you. Please help her biological clock from ticking forward.
Ma'am, as you told about this, ma'am, is it any legal implications? There are some queries by the doctor. Is it any legal implications for this egg freezing? Any other specific permissions?
2012, ASRM declared it as before that it was experimental, but now it's non-experimental. It's absolutely legally permissible.
Ma'am, for that they have to take any other additional permission from the PCP and DT?
I mean, if you have an IVF permission, that's okay. You don't need
it. Yeah. Ma'am, as you mentioned in your lecture, that every time we have not to be focused on a single AMH reading. We have to do at least 2 AMH readings, minimum 4 to 6 weeks apart.
2 to 4 weeks.
2 to 4 weeks.
Patient will go to another center.
Another doctor, So, ma'am, so in between this 4 weeks, 2 to 4 weeks apart, what's your protocol? You start at that time the supplements, or you start only after the 2 readings?
No, I start after the 2 readings, but I don't give DHEA plus, but I give arginine, I give CoQ. I just hold DHEA.
Okay, ma'am. Thank you so much, ma'am. Vaibhav, any questions, ma'am? Because so many doctors joined via Facebook and YouTube live.
Oh.
Ma'am, here to all are congratulating and saying excellent lecture. Vaibhav, please share the questions here. If any questions are there on the Facebook. Ma'am, only 1 second. I'm just checking for the question.
No problem. I think it was, how long did I talk?
40 minutes.
Oh my God.
Oh, that was amazing, ma'am. Ma'am, see, so many compliments are now coming. Dr. Rosie Sharma, really very good lecture. All are complimenting. So thank you so much, ma'am. मुझे तो इतना अच्छा लगा. मुझे लगा मैं एकदम अकेली student होकर मैम के साथ पढ़ रही हूँ. I got that privilege. Thank you so much, ma'am. Thank you, ma'am, for enlightening all of us. Ma'am, all are giving the compliments. Yes, all are giving the compliments.
Thank you,
ma'am, for giving your precious time to me. Thank you so much, ma'am, enlightening for all of us by your immense knowledge. Thank you, ma'am. Thank you once again.
It was a pleasure.
Yeah. So with this, friends, we are winding up now today's session. Thank you to InnovaCare Life Sciences also, constantly doing this educational activities. So friends, it's the full September and October month, as our Foxy is full of gurus. So I am celebrating this full September and October month as a Teachers' Day celebration. All the stalwarts are on this my show. Then again on yesterday, all of you have heard the Dr. Pai sir, today the Nandita ma'am, and next week we are having the Dr. Rishma Pai madam and Dr. Naren Malhotra sir. So friends,
I think, Ritu, I want to say thank you to everybody who is logged in. I mean, it's a pleasure that you're all there, and thank you, InnovCare. I think Sankalp, and it was really nice of them to arrange it, and I'm so happy. Are they still there?
yeah. Over to you, Sankalp. Are you here?
Poor guys.
I don't know whether they are there or not. Yes.
Madam, I'm saying, before our career, when we started our career in this field, we used to meet you till 9:30, 10 o'clock. We used to wait there in the Opera House to meet the call.
I know.
Thank you so much, and I'm very happy to see you that you have come on our show. This is our own company, ma'am. InnovCare Life Sciences is our own.
Achha, okay.
And we feel that because of your help and kind support which you have, helped in the earlier days, we have reached this level.
I can't say no to Ritu.
Thank you so much, ma'am. Thank you so much, ma'am.
It's always a pleasure with so much of honor that you've given me. I think I really enjoyed it, and I also enjoyed it. You could see I was enjoying myself.
Thank you, ma'am. Thank you so much, ma'am. Ma'am, we are lucky to have you.
I'm sorry.
Thank you very much.
Yeah.
Thank you very much, Dr. Nandita. Thanks a lot, Dr. Ritu. Thanks a lot.
Okay, thank you, Ambeji. With this, friends, we are winding up today's session. Stay safe, stay healthy. Good night to all of you. Bye-bye.
Good night.